this is the first time that we have such a conference going on, which is also open to a large number of people. The Integrated Health and Wellbeing Council has put this together. And so when we first asked the question, what does flattening of the curve mean? Professor Kishore basically told us in epidemiology, in public health, we have something called the number of cases that come in. And when we plot it on a graph, we essentially see the numbers rising, and that kind of gives us a peak on a graph. It tells us the total number of people that are coming in sick over what period of time and how it rises and kind of continues on. So the total number of new people plus the old number of people that are already sick become people under the curve. Sharper the number of the new cases coming in, the higher the peak. That needs to be brought down, which essentially, translating what Professor Kishore has said, we need to reduce the speed at which the number of people are becoming infected and also the total number of people that are being infected, which results in a flattened curve. Instead of it going like this, it'll go like that. And that is what is essentially meant. And spreading that out requires a certain set of measures. What are those measures is the question that I will now pose to Dr. Sanjeev Kumar. Sir, everybody's talking about lockdowns, everybody's talking about isolation, social distancing, quarantine. These are also, again, very technical words. I asked first the professor, what is a curve like? Now these are also technical words. In very simple terms, what do these words mean in flattening the curve, which Professor Kishore has said we need to get done? Professor Kishore, if your thing can be on mute so that Sanjeev can come along.
Professor Jugal Kishore has very well explained what is meant by flattening the curve. In simple words, if one patient infects 4, in 5 rounds of infection, the number become 1 to 4, 4 to 16, 16 to 256, and then from 256 to 65,536. And in another round, it will be 65,536 into 65,500. Billions of people will get infected. When we put in place measures of social distancing, like
इसका मतलब क्या हुआ? सोशल डिस्टेंसिंग का मतलब क्या हुआ सर?
बिल्कुल, सोशल डिस्टेंसिंग के जो कंपोनेंट हैं, कुछ तो सरकार करती है और कुछ लोग कर सकते हैं. तो वो जो सरकार करती है, जो केसेस आए उनको जल्दी से जल्दी डिटेक्ट करके उनको आइसोलेट करें, उनको अस्पताल में आइसोलेट करें या घर पे आइसोलेट करें ताकि वो इन्फेक्शन को आगे नहीं स्प्रेड करें. दूसरा, सरकार लॉकडाउन करती है, जो कि आजकल चल रहा है पूरे देश के अंदर. पीपल कैन नॉट गो आउट इन द पब्लिक एंड then you have to do measures yourself. People are the nucleus of any stopping or flattening of the flattening of the curve and spreading of the disease. You have to follow measures. Don't get out of the house. Wash your hands frequently and try to avoid going to places where you meet large number of people. By doing these measures, if you slow down, one person infects 2 persons, then it becomes 2 to 4, 4 to 16,
right,
6 to 256. You know, from 65,000, you have reduced the number to 256 in 4 rounds. This is precisely what social distancing does to flatten the curve.
Thank you, sir. So if we do these things, if you can mute yourself now, thank you so much.
Yeah, sure.
Then what Professor Kishore said will actually happen, which is the rate of the rise of the curve and the height of the curve will both come down, which allows for a slowing of the number of people that will fall sick. Let me turn to Professor Agarwal. Dr. Agarwal, what happens if too many people fall sick at the same time? At a hospital end, you're kind of looking at the medical associations, all the medical practitioners. What happens if too many people come in? Shouldn't the hospital be happy? Arey, hamara hospital bhar gaya hai. What is the challenge that you are thinking of when it says too many people are coming in?
So let me explain it, starting from isolation and quarantine, coming back to the hospital. Now, the effect of this lockdown will not appear on day one. Whatever the number of cases is appearing today will depend upon the infection which have occurred 5 days back, because the incubation period is 2 to 14 with a mean incubation period of 5.9 days. So therefore, we expect some reduction in daily cases starting from 27th in Delhi and starting from 31st all over the country. Time to death is 14 days, so we will keep getting deaths occurring till 14th day of the lockdown. And after that, we start expecting the reduce in death rates. And if that doesn't occur, that means then somewhere we are wrong. And that wrong will only happen if we don't do testing in the first week. In these 3 weeks, the first week is very important. And in the first week, we should be able to detect all those cases who are asymptomatic. So therefore, in the first week, if we are not going to be liberal in testing, and if these people start getting infections in second week and then they have to be isolated for another 2 weeks, by the end of 3 weeks, they will be frustrated. Because it will be something like they are now waiting for 21 days, 21 days. And if this extends for them forcefully because they were not detected in the first week, they will be in trouble. And for that, Indian government yesterday has come out with the telemedicine guidelines. These telemedicine guidelines suggest us that we have to call the doctor on phone and he will judge you and triage you on phone. So triage on telemedicine now facilities are available. Remember, अगर आपको खांसी है तो वो take it as a pollution, खांसी के साथ में जुकाम है तो एलर्जी हो सकती है, साथ में बुखार है तो ये फ्लू है. Only 4% will have COVID, लेकिन सिर्फ खांसी है और बुखार है और सडन ऑनसेट ब्रेथलेसनेस हो रहा है तो कोविड का टेस्ट कराओ. Don't ignore that on the first 7 days. Therefore, triage has to be done on telemedicine, number one. Number two is your doctor, if you have a simple SpO2 monitor at home, even if your colony has, and in that case, if you see that your breathlessness is not showing fall in oxygen, even if you have a minor pneumonia, you can be managed at home. So as long as possible, if you manage at home in the first 21 days, your requirement to the hospital will go down. And we even have suggested that COVID positive cases not dependent on oxygen should not be admitted in a hospital. If you want to conserve them, take them to a hotel or take them to a place which is away and in a resort, but not in a hospital. In a hospital, we expect not more than 3 to 5% of the society who is getting infected and developing it. Now, people are estimating very, very, very high numbers. I take the worst scenario, and the worst scenario is in Italy, which is 0.1 per million population getting infected. That much of facilities. If we triage all our cases, we should be able to do it. But the only thing is, government in the meantime must ensure availability of personal protective equipments for the healthcare providers.
Right. So thank you, Dr. Agarwal. One key thing that we need to be mindful of, and because it's not a small closed conversation, many people, I don't know where all from, have logged in to watch this. So this is also what we're speaking is both technical and also of public communication value. So sometimes I will rephrase some of the things that we have said. Of importance, what Dr. Agarwal has said that we need to be mindful of is not every little cold is immediately telling you that you have a serious illness. If you have a cold and if you have got a little bit of a cough, no fever, then please do not get alarmed immediately. If you've got a cough, a cold, and you've got the beginnings of a fever, do make sure that you are asking for a telephonic consultation. And if you're running short on breath, then definitely the helpline numbers that are there are the ones that you should call on. अगर ये नहीं है और हैं भी तो सबको हॉस्पिटल आने की जरूरत नहीं है. आपको कॉल फैसिलिटी की सुविधा दी गई है, उस नंबर पे आप बुलाएं और वहां पे आपकी ट्रायज होगी फोन पे और आपके सिम्टम्स के अनुमान के हिसाब से आपको गाइड किया जाएगा कि आप घर में ही रहें या फिर आप अस्पताल में आने की जरूरत है या नहीं. If you don't need to come to the hospital, please stay home because it keeps you away from the risk of contracting another infection. Last thing is, we do not want people to fall sick to an extent where they're going to need a hospital bed. Too many people needing a hospital bed is something that puts a pressure on the already limited supply of beds and healthcare personnel that we have. That is something that we need to be avoided. Last thing that I want to pick up, and that's where I will pivot to Dr. Priya Abraham, who's just joined us from the director of NIV Pune. What Dr. Agarwal has said is this, that we should be in the early days of our lockdown, be smartly using testing. And I believe that testing is becoming one of those awkward words for everybody around. Do we have enough tests? Should we use it discriminately, indiscriminately, judiciously, sparingly? You are at the, let's put it, say, eye of this testing storm. You're both certifying tests, you're validating the tests that have been coming in. What is our approach, Priya ma'am?
I would really like to echo the words of the previous speaker, test, 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 because we really need to understand just how much of a problem we have in our country. So yes, as you know, NIV was the first institute to start the testing, but we have empowered about 102 other laboratories within the DHR ICMR system to start testing. And we continue to handhold them. As we speak now, there's a medical college from Goa here who has come to be trained hands-on, and they will go back with reagents to start testing in Goa. So that is happening in the DHR ICMR system. We've also opened it to some of the non-ICMR facilities to start testing. And I think another more recent development was the fact that ICMR was able to communicate the assays that were validated by us at NIV, which could be used by private laboratories. That's up on the ICMR website. We will continue to validate whatever comes to India, submit it to our headquarters, and that will get onto the website. So people will have a larger, array of tests that they can source with the validation criteria. So therefore, they can, whatever they can grab their hands on, they can use for testing both in the private and in the public facility. So I would think that's the way to go.
Right. Dr. Thank you so much for saying that test, that we are not backing away from that. We are increasing the availability of the testing capabilities. You're now authorizing private laboratories. We already have 102 from the government setup. And so doing the testing, now going back to what Professor Dr. Agarwal had said, figuring out how we isolate people so that the social distancing or the removal from the pool of transmission is taking place, so that what Professor Kishore right in the beginning told us, that we can flatten the curve. How do you go about, Dipanjan, I'm turning to you, Priya ma'am, you can mute yourself now. Dipanjan, you have been in the business of enabling smart testing or figuring out where the cases are from your background in HIV and other infectious diseases. How do we take the tests that are available, say, from the NIV labs and in the private sector, utilize it in such a way that we are able to pick up people before and are able to make sure that they do not become too sick?
Thank you, Bobby. And good afternoon to all the esteemed speakers in the panel. Echoing on the thoughts of everyone, it's a very challenging time for all of us across the globe. Let me take the question head on and start mentioning that yes, testing is authorized. We have got 102 laboratories, which are 119 have been proposed, out of which 102 are currently functional, as Dr. Abraham was just mentioning. And also there are a lot of private players, around 18 of them, who have been sanctioned to do the tests. Having said that, who are to be tested? Now, there's an ICMR protocol available, which allows us to do testing for folks, and it has been little, expanded to include the contacts right now. We still haven't really got into the asymptomatic phase. The one question you wanted to home on to is that we need to identify people early, right, before they become spreaders and make the disease to a much larger extent than it is currently is. In order to do that, we need to incorporate others into the system. That means those who are, asymptomatics and others in the contact list. But to do that, the first thing is the number of tests availability in the country. Fortunately, the government has already authorized, we do have Roche, which has been approved. We have MyLab from Pune, which has been approved. And I think Dr. Abraham can give more details on that, which are the other companies which have been approved. But even in that, we need the number of tests and availability across all the centers and a strict, stringent protocol to do that. It's not that easy, because many of the other laboratories, I know of many laboratories across India which are doing some of the other tests which may not be appropriate or even authorized by certain, at least our governing system and the legal system in the country. So we need to have a regulation, we need to have a good supply chain management and authorization. And I think the NIV and the ICMR is taking a lead on that. So I'm very hopeful of the things to come in future.
Sure. So, and I'll come back to that, because you've kind of taken the broad principles of the testing strategy, but who do we test? I mean, at what time? I mean, like, again, I go back to what Dr. Agarwal had said right in the beginning. I mean, when he was speaking, there are people who will feel unwell. Do all merit a test? And how do we do that? Dr. Agarwal, I mean, if you can kind of come in here.
I want to add something. See, when we talk about asymptomatic, there is a confusion. People feel no fever means asymptomatic, I only have cough. Remember, 44% of cases, fever will be the only first manifestation. So fever may come a day later. On the first day, you may feel tired, you may feel headache, you may feel absolutely lethargic. And people will say, I'm asymptomatic because I don't have fever. That's one. Number two, I have a couple of my friends. See, I'm currently the president of CIMA, so I've been talking to most of the countries. And the South Korean country says the typical feature has been, much before the fever, has been loss of smell and loss of taste. So anybody who says in this particular time, oh, suddenly I've lost the smell and the taste, the fever may come 2 or 3 days later. At that particular moment, you don't need to miss it. The third thing which I am doing is, Aram is live on my Facebook Live. So I'm spending 3 to 4 p.m. every day with the people. So what we are doing is asking them, anybody who says I'm cough and cold, I says, get a TLC done and come back to me within an hour. TLC, normally in every viral fever, you should have lymphocytosis. In this way, you have lymphopenia, which we normally say is an acute HIV reaction. And if you can demonstrate that there is a lymphopenia, if it is less than 1,000, we know it is serious. If it is between 1,000 to 3,000, you know that you may be dealing with a COVID illness. Yesterday, only one of the singer called me up and he said that he's having cough and fever. I said, get the lymphocytic count done. His lymphocytic count was only 1,200. So the report is awaited today. So I'm also doing a clinical triage of cases to detect them from CBC. Then you can have ultrasound labs can pick it up if you have fever with cough. As we used to pick up a lot of dengue with the ultrasound diagnosis of gallbladder fluid accumulation. Similarly, in an ultrasound, if you can pick up a interstitial pneumonia, you know that this breathlessness is COVID unless proved otherwise. So every sector of the society, the radiologists, the ultrasound pathologists, should be able to say, oh, this may not, I hope you are not suffering from COVID. So it is not necessary for us, even if the tests are not available at this particular moment, every sector can come forward and help in diagnosis.
Which is great. I mean, it gives me a real good pivot point to come bring a Rajiv Gautam, who happens to kind of represent the private sector here with rapid CBC and CRP testing facilities. Because as Dr. Agarwal said, it is the one place, I mean, it is not just the specific testing that alone can kind of throw up the numbers. Opportunistic testing from the peripheries and adjacencies can also enable people to be picked up. So if you've got a slightly awkward, let's put it this way, blood count profile, that allows for an index of suspicion to be pointed towards this might be something. And so therefore, Rajiv, I mean, bringing you here into this conversation with all the other professors, I mean, you're coming in from the provisioning of a test side. People like you and the labs, I mean, what is it that you can do to enable more people to be tested for in a triage fashion? And then I will come back to the other panelists to then go deeper into some of these questions. But Rajiv.
Thanks, Bobby. And I think the experts has already told about the diagnosis. So let me not talk about diagnosis. But what is more important is monitoring and taking care of the patient with sequential assessment of critical status, which involve inflammatory, immunological, hemodynamic status. As of today, the studies from Wuhan shows that the CBC along with the CRP can be used to a large extent to assess the critical status of infected patient. So the problem with the public health care is that, okay, somebody is sanitized or somebody is quarantined. How you know that whether it is getting more ill or it is getting better? So you can check with the CBC and CRP. And Horiba has a machine called micro-ME-CRP. It is from Japan. It's a 4-minute test. It can be done near patient. You just need a finger prick of blood. You don't need a serum. You don't need any expert laboratory technicians. And it can tell you what's the CBC and CRP. It's just 4-minute test. And then you can just monitor it, that how the CRP levels and CBC levels as Dr. Gawal told about the lymphocytes situations. So you can monitor it, whether a drug is affecting it or patient is getting more ill and more is getting better.
Thank you. Which then kind of brings me back full circle back to the professor of community medicine here, Professor Kishore. Because full circle, if you want to flatten the curve, and flattening the curve means making sure that the rate of people falling sick is coming down, you're slowing down that spread, enabling more space and capability available for taking care of sick people, and you have, let's put it this way, in your toolkit, both the instruments of lockdown and then other instruments of tracking people's sickness, how bad they are, how badly are they progressing, or how quickly are they kind of getting better. How would you put it all together into, let's put it this way, an overarching toolkit as somebody who kind of both teaches and practices public health?
Yeah, it's a very nice question. When we say public health action, it is a comprehensive, interventions are required for any kind of disease, which is of this kind of corona. Now, I can recall the same way which used to be in undergraduate, that we have, 5 level of interventions, where we have first the health promotion, specific protection, early diagnosis and treatment, disability limitation and rehabilitation. So whenever we are dealing with such kind of pandemic, which can have very huge impact on everything, not only just, the death, which is the focus today, but we have to think in other line, because it has the economic impact, we have, psychological impact, we have the social impact. So everything to be, handled at the same time. It is to be taken care of. So in health promotion, which is rightly going on, that we have the social distancing, and, we are talking about the individual, how they have to keep themselves, healthy, and how they have to maintain their diet, their sleep, their, hygiene. All these are, making them more immune and more, good in their health. But at the same time, we are talking about early diagnosis, that is a screening and test, is possible. But remember that we have a very huge population, 1.3 billion population. And if with the rate it is going, the transmission, if it is the R is reproductive rate is 2.1 or 2.3, then we were not able to test everybody. It is very, very difficult. Today also, if you see, even the government hospital, like the, major hospital, we don't have a testing facility. So just, even if you try, in next 1 to 2 months, we will not be able to have the good amount of testing of the people. So what is left is us, with us, these kind of measures like the total lockdown and, very good health hygiene and practices. But I'll tell you that we have to move beyond, and that is the disability limitation and rehabilitation. Now you are seeing that lockdown is creating a lot of problem. The people are not having food to eat.
We will come there. We will come there, sir. We will come there because each of them is another thing.
At the same time, these all things to be taken care of.
Right.
Then only we can say it's a comprehensive measure. Otherwise, we will lose the track and may have very bad impact of this pandemic.
Thank you. I mean, three things that Professor Kishore said, which I want to kind of pull out. One is that we should not, this is not just about death. There are things that are happening in between that we need to be mindful of. There is an economic impact of locking down a whole country or the situation that we are in. We've never seen this before. We need to be mindful because then when we come out of it, there'll be a lot of people who will be far lesser in their resource capabilities than what we started off with. There's a phenomenal destruction of resources that's taking place as we're speaking, and not just in terms of people dying or falling sick. There is a psychological component to it. People being locked in, especially in small spaces, small children, elderly parents, and not being able to go out, lack of information, lots of misinformation through WhatsApp and social media channels. Everybody seems to be an expert in one field or the other, gives rise to a lot of anxiety. And so therefore, even if we don't have the physical sickness that is COVID related, a second order effect is that there will be a lot of people who will need help in unburdening themselves. And that is a big ill health scenario that we are doing. And the last bit is this, the social unwellness. Even where I'm staying right now, I can see neighbors getting onto each other's nerves because they want to get something before the other person. Khatam ho gaya to. And that anxiety, that panic behavior causes out a lot of problems. And so therefore, in addressing that, what is the role of the healthcare professional? And then I want to kind of turn to Dr. Agarwal here. Because again, when you look at the entire medical association and the large bodies of medical practitioners, not everybody is going to be an infectious disease responder. A lot of people will be drafted into it. But there are these other things that need to be also addressed. How is the call going out to the medical associations and the larger medical community right now? And I know that you need to also leave. So if you can answer this and then leave, sir.
First of all is the manpower. So Indian Medical Association has suggested that you allow final year MBBS students to participate in the clinical care if needs. Nurses may be given restricted powers to do a virtual ICU where the senior doctors can be available virtually, and a lot of the people are working on the field are younger people. In Italy, the highest age of a person working in intensive care was only a 40, with the majority of them young women working. All Chinese doctors who are Chinese and other countries doctors who are awaiting for examination can be enrolled, like if the government of India and the Supreme Court can say that give parole to all the prisoners in the society with less than 7 years of imprisonment. Similarly, you can waive off the examination of all the 1 lakh doctors who are waiting for their exam, involve them in an internship, and make them an army if they require. So these are a couple of things which Indian Medical Association and CIMAO, as a CIMAO, we have suggested it in all the 19 Asian medical countries. Before I end, I also want to say is that for me, COVID is an opportunity. It's not a disaster. I want, once the COVID is over, in India to be more healthier, less typhoid, less diarrhea, less pneumonias, less flu. Pollution will disappear. We now have an answer in Delhi pollution, lockdown for those 5 days. Why are we just 5 days? Because now today's pollution in Delhi PM 2.5 in the most polluted area is 24. So we have now got a study which tells you, and I also got today I've been following the deaths occurring in Delhi, and in the Nigambodh Ghat yesterday there were only 21 deaths as against 50 normally. The deaths are also going down. So we will come to know what are the number of deaths which occur because of hospital-acquired pneumonia and which occurs because of traffic accidents. Because that
Thank
number
you.
of, suppose we end up into 50% reduction in typhoid, jaundice, diarrhea, flu, and other deaths, even heart attack deaths will occur because the stress level will go away. People will learn to meditate. This is the first time people will understand how to give time to yourself. अभी तक लोग कहते थे कि मेरे पास time ही नहीं है. Now everybody has a time, and that stress may reduce the precipitation of heart attack and death. So I only want to say is every adversity is an opportunity. Let's take it, let's do it, let's relearn, and let's relearn our way of life, the purpose of our life. Maybe COVID has come back to teach us what in a Kal Yug, what actually a Satyug was, and what is a different type of a feeling is. So I convey, Dr. Bob, to all of you, all the best. Bobby specifically calling me here because simultaneously I'm also on a Facebook Live. I have at least 100 questions to answer. I would like to say Corona Namaste to everybody, because if we do a Corona Namaste, at least we will be able to prevent transmission of COVID-like illnesses in future. Thank you.
जी नमस्ते भी कह दो, आदाब अर्ज भी कर देता हूं कि दोनों तरफ से ये ट्रांसमिशन में हम ब्रेक कर सकते हैं. And what Dr. Agarwal said is, I think, an opportunity both for Professor Kishore. I think you've got several natural experiments happening right now. Almost immediately, if your MD and MPH students are able to pick up some of these areas of work and do the baselines and track it over a period of time, we will not get such opportunities in a natural sense. Trying to do an institutional review board for such experiments is not going to be ever possible. And so therefore, using that would be very, very important. But, and I also want to kind of also point to Dr. Priya. I think with everybody talking about, I hope that this also sparks a lot of interest among people who will want to do biomedical sciences. Suddenly, I mean, it's not the age of IT and IT enabled. We need that, but a renewed interest in this is something that I hope it happens. And you are a degree granting institution also from the NIV through the ICMR network. Where do you see that opportunity? And I will come back to then Dipanjan and to Professor Kumar separately.
Actually, in this whole venture, we have seen some of our own postgraduates being one of the first to isolate the coronavirus, the SARS coronavirus in Canada. Our own postgraduate from here, who's now on the faculty or a scientist, she was instrumental in isolating the coronavirus here in NIV. And one of my own students from CMC Vellore, my own PhD student earlier, he's leading the team in IIT Delhi. So you actually see that there is a huge future for students of biomedical sciences in situations such as this to, take up the torch and run and do the best that they can.
And this is where I'm kind of particularly delighted that Dr. Priya is here, because here we have, when everybody talks about NIV and somebody who's kind of leading the whole effort, we also need to notice the fact that it is a lady, it's a woman who's actually at the helm of this. And she also kind of points out that the Canadian graduate from India is also a woman who's actually been at the forefront of doing this. And so therefore, I'm hoping that this also signals very positively to an increased number of women candidates who are coming into higher levels of their training and leading the research and response efforts. And so that, in that sense, I want to kind of appreciate your presence and your leadership here.
Thank you. Thank you so much, Dr. Bobby.
Which also turns me back to then Dipanjan and then to Dr. Sanjeev, because I'll leave this session because we've got another couple of minutes. Dipanjan, again, everybody's talking about R0. There is, I was very facetiously saying there are a couple of epidemics going on. One is a misinformation epidemic. There is an actual COVID epidemic. And now I believe there's a new epidemic of mathematical modelers and public health specialists. Everybody seems to be wanting to become a public health specialist. As somebody trained and somebody who's been at the forefront of this, where do you see this scenario now helping us in the future?
Thank you, Ravi. I think you brought a beautiful question. Lots of misinformation campaign, but let me take up the R0 or the transmission rate for COVID-19 virus. As of recently, the WHO had calculated it between 1.5 to about 2.4. The Wuhan study recently done by the backdrop data, which was done by the Italian folks back there, they had mentioned it as 2.2. Okay, that's basic reproduction rate. I'm talking in pure technical terms. Let me be a more layman specific. What does it mean? It means that any infected patient could potentially, or infected case can potentially infect another 2.2 people. Okay, that means if there are 10 cases who are infected, 22 folks would get infection from them during that period. So that's the kind of basic reproduction rate which we talk about or are not. Having said that, yes, there's a plethora of modelers because we have done initial modelings and my career spans with HIV for a long period. So we have done lots of modeling cases in this, either while my tenure with CDC or with WHO. So in those two scenarios, we had seen lots of these modelings coming in. But many modelers, for that matter, are, it's all assumption-based approach. We have just got one case study from China. We have got another scenario in Italian setups. We have one from South Korea. We have one from Japan. We have got some cases, current situations from US as well as from the UK and the European Union in general. So putting them in the models, we are assuming many things which happen. Many modelers will come up, but in general, I go back to the simple thing is whatever kind of testing or factors you do, you need to put in the measures of control or public health measures as aptly pointed out by the eminent speakers. So I rested there.
So, yeah, you rested there. I have to my job is to translate. I mean, you started off, saying, yes, there's interest, and then you lapse into technicalities. I hope that the people that are watching this will get a glimpse of both the complexity and also the opportunity that public health and epidemiology particularly provides in doing great good. You can come from the world of mathematics, you can come from the world of economics, you can come from the world of sociology and anthropology, and you can bring all those skills into modeling out how does our behavior transform disease dynamics. Can we be more healthy? Can we be less healthy? And it is not just the clinicians alone who will be able to sort this out. We need all kinds of skills. And it is unfair, and I can see that, and I want to make an editorial comment here. It's unfair sometimes to see economists being booed out because of the models that they are presenting. They may be actually more valid than sometimes just the clinicians doing their own work. In the world of epidemiology and public health, we are not restricted to people who have an MBBS and MD degree alone. We recognize the need for many, many people to come together and work together, bring their multiplicity of skills, because we recognize that health is not just merely the absence of illness, but it's complete physical, mental, and social well-being, and that requires many other skills. And which is where I want to turn back to Dr. Kumar. I mean, you've seen this whole thing from the Public Health Association, the Indian Academy of Public Health. How do you see this now? We started off asking about flattening the curve. We've looked at the opportunities that may be there for the clinicians, for the public health specialists, for the biomedical folks, for those that are in the private sector to bring in new tools. How do we use all of this together now to both flatten and extend the curve and look beyond to a time when, let's put it this way, not a post-apocalyptic, but a post-corona world?
First is, I will come back to the model. Models are useful. These are the ones which help us in projecting how many cases we will see and what are the resources we need to line up. So for flattening the curve, models are very important. There are many of them because these are based on presumptions, but they give us very valuable insight. By flattening the curve as a public health person, you gain 5 things. One is you don't overload the system with huge number of cases. Second, you get time to build the capacity of the system. We talked about testing. Similarly, huge capacity has been built, which is called surge capacity in indoor patients, in ICUs, roping in large number of hospitals. Third is we buy time for researchers to tell us which medicines will work, and also give time for the vaccine which may come up. But keep in mind, we still don't have a vaccine against HIV, so don't put all your hopes in the vaccine, but it gives you time. Fourth, it gives you time to learn from global experience. Each country is suffering. As of today, 196 countries, almost all countries, and each one of them has a lesson for us. Fifth is mobilize resources. The lockdown is just not health, it is all the sectors come together. And economic impact, you talked about daily wages, labor, how do you take care of them? Second aspect, from public health point of view, I want to emphasize, not everybody gets sick in an epidemic. The mathematical models again range that 20 to 60% of population will not get infection. They will be asymptomatic even if they get infection. So roughly half, we don't know. Figures may change as we get more information. Those who get infected, 80% will have mild sickness. They can be treated at home. 15% may need hospital care, and 5% may become critical and they may need care like ICU. So this is the distribution in population. Coming to infodemic, you talked about, I abbreviate is as idiot. Let's not become idiots. Idiot is internet derived information obstructing truth. So lot of infodemic is happening and we are all becoming idiots. I get 90% queries to me clarifying this is not true. So let's not become idiots, get the true information from reliable resources so that we can address and play, each one of us can play a role. Public population is the most important. We have to take the lead. Government can provide resources, but it is you, me, and the man on the street who has to make sure that they do what they want to do, they report at the right time, don't overcrowd the system, stay indoors, wash hands, and bring down not only COVID, many other diseases, as one of the speakers earlier said.
Yeah, thank you so much. And so, I mean, there's an excellent summary points that I want to kind of reiterate. What we are doing right now, as Dr. Kumar said, is we are trying to buy some time. We are trying to prevent an overload of our system during the time that we have bought. We are trying to build our capacity, or the surge capacity that Sir is saying. What if another 300 people came in sick all of a sudden? We have the capacity, and we are building that. We are also using this time to look at other people's experience, learn from their mistakes, and try and see what we can adapt to us locally. In the meantime, hoping that our bright, young, and older researchers will all put their energy and their wisdom so that we have breakthroughs, whether it's in the vaccine or whether it's in the better diagnostics or whether it's in a better management space, and be able to give help to others. All the while being cognizant that this is an economic issue too, and we need resources. As it is, health resources were always scarce. Health was never prioritized. For the first time, one of the side effects of this, apart from the clean air and the lesser number of vehicles on the road, is the fact that we have a prime ministerial level attention on health, and that the entire government is right now today in some ways being led by the health ministry. And so in that sense, it's a wonderful opportunity, and we should be mindful that we use it responsibly, both to save lives and to set up our approaches in such a way that we have a continuous stream of innovation, application, and execution that allows for better, healthier, longer lives. Thank you so much for being with us at the ISW virtual conference of the coronavirus epidemic that we have right now. For the work that you're doing, for all the things that you're providing leadership for, we appreciate you, we thank you, and we thank you particularly for your time that you have spent.